Okay, okay.
Your voice is breaking, sir.
Sir, I am unable to share my screen, sir. Can you make me a host, sir?
1 minute. Actually, anybody can share and make you co-host. We are now live on YouTube also, sir.
Okay.
If you are able to share, then we'll start the meeting. Okay, before that, I welcome you all for this 10th edition of IAP CCB virtual Gurukulam program. This program graduates asking me undergrads can learn. So it of audience, even undergraduates, you have everything on YouTube. So the past 10 editions was absolutely, past 9 editions are absolutely good teaching material for undergraduates, for practicing pediatricians, for faculties. They can view that, and they can even get a refreshment before some classes or something like that, before exams or something like that. So I said even undergraduates also can join. I welcome today our convener, Dr. S. Balasubramaniam sir. Sir has been our pillar for conducting this program throughout this year. I also welcome mentor Dr. Janani Madam. Dr. Janani Madam is Medical Director, Kanchi Kamakodi Child Trust Hospital. Two of them are like my two eyes, my teachers when I studied in Child Trust. So I'm very happy to have them here now. And then I also welcome Dr. Rajkumar. Dr. Rajkumar is undergraduate from Tanjore and postgraduate from Stanley Medical College. He's my close associate. He's working in Chettinad Medical College as professor of pediatrics. I welcome you, Rajkumar, for the show.
Thank you, sir.
So today we have a presentation from Mehta Children's Hospital. The PG Dr. Divya Senthil Kumar is going to present from Mehta Children's Hospital. So our idea is to involve all the colleges and the institutes in Chennai. So one mentor from one institute and a postgraduate from another institute, so that we have representation of all the colleges. So by this 10th show, we are able to cover almost all the colleges in Chennai now. So with this, Somasundaram sir, you want to tell a few words and then we'll start. Yeah, you're able to share your slides, pa. You can wait. Divya, your slides are being shared.
Yes, sir. Yes, sir. Thank you, sir.
You can wait.
Yes, sir.
Somasundaram sir.
So first of all, welcome you all to the 10th session of
virtual curriculum, the postgraduate training program of IAP Chennai City branch. So,
sir, you are not audible, sir.
I think his connection is lost.
Yes, sir.
Yeah.
So I think there is only one message from Somasundaram sir. The important message is this weekend, Sunday, Marina Pedican is going to happen in Savera. So I hope you would all have got the links for registration. The post-graduation registration is still open and it is only 1,000 rupees. So the post-graduation fees has not been increased. So if you can still register as a postgraduate and it is only 1,000 rupees, you have all the stalwarts, including SBS sir, Janani madam, everybody is there in the program. And for the PGs, the award paper that has been selected. So the award paper A Parsadi CCB award will also be there. So I request all of you to register. So I think that is the only message that Somasundaram sir would like to convey to mainly. So we'll have him at the end. So without wasting much time, I think we can start. Shall we start, sir?
Yes, sir. Sir, Prasad, sir, am I audible, sir?
Yeah, you are audible. Raj.
Okay, okay.
Shall we start, madam?
Yeah. Fine.
Yeah. Okay. I also welcome Dr. Nisha. Dr. Nisha is also here. Nisha is the co-host for today. She is the treasurer of IAP CCB. Madam, you have to unmute, madam. Nisha, madam, you have to unmute.
Thanks.
Yeah.
So we'll start.
Yeah.
Am I audible, Prasanna?
Yes, madam, you are audible.
So shall we start, sir?
Yes, sir, you can start.
Good evening, I am Dr. Divyaja, post-diploma DNB PG from Mehta Hospital. I would like to thank IAP CCP for giving me this wonderful opportunity. I would also like to thank all my professors for the abundant guidance and support. My special thanks to Dr. Tagwil sir. I would like to start now. This is Jaswita, a 2-year-old female child, second round of non-consanguineous marriage, residing in Chennai, whose informant is mother, whose reliability is good, brought by the parents with complaints of fever for the past 7 days, skin rash noted for the past 3 days, abdominal distension noted for the past 3 days. The child was apparently normal before 1 week. Then the child developed fever, which was high grade, intermittent, relieved by medication, not associated with chills and rigors. History of reddish spot noted over left leg and back. First noted 3 days back, which turned into reddish blue color now. Abdominal distension, which was interior in onset.
What do you think of this reddish spots, sir?
Sir, reddish spots turning in blue in color means bleeding spots, sir.
Okay. Now, what is the commonest cause you think of if child who has a fever with bleeding?
Tropical infection, more probably dengue infection, sir. Dengue
Okay.
fever.
Anything else?
It can also be septicemia, meningococemia,
Okay, good.
leptospirosis, viral hemorrhagic fevers.
Okay.
Not common in our geographical area, Ebola. It can also be protozoal infections like malaria, other hematological conditions.
Okay. What is the basic pathology of bleeding in all the causes, all the conditions as causes?
In viral hemorrhagic fever, direct viral injury to the endothelium causing increased permeability of the endothelial wall, causing bleeding manifestation. In leptospira and enteric fever, due to liver involvement, decreased synthesis of vitamin E K dependent clotting factors like 2, 7, 9, and 10, causing bleeding.
How about dengue?
Septicemia and dengue In dengue, direct viral injury to the endothelium, sir. Thrombocytopenia, qualitative and quantitative effects of platelet can cause
Okay.
bleeding.
Was this reddish spots associated with trauma?
No, sir. No history of trauma, sir.
Okay. So it is spontaneous bleeding, right?
Yes, spontaneous bleeding, sir.
Okay. Now, what is the platelet count below which you can get a spontaneous bleeding?
Below 20,000, we may get a spontaneous bleeding.
Okay. Go on with the presentation.
Abdominal distension, which was insidious in onset, noted for the past 3 days by the mother, involving the upper abdomen, not associated with history of facial puffiness, swelling of legs, difficulty breathing, diminished urine output, yellowish discoloration of eyes, blue stools. No history of coughing.
Dr. Divya,
Yes, sir.
can you come closer to the mic and speak? Your audio is not very good.
Sir, am I audible now, sir?
You're audible
Yeah,
now.
better.
Yes, sir.
Divya, what do you
of
think of a
coughing.
child who has a fever with bleeding, with abdominal distension on the third day?
Tropical infections with
Okay.
thrombocytopenia.
Okay. Why there is abdominal distension in?
Liver and spleen involvement, sir. The mother
Okay.
says upper abdomen is more involved. So it
Okay.
might be a organomegaly, more probably a organomegaly. So liver and hepatosplenomegaly could be there. So fever with bleeding manifestation and hepatosplenomegaly. We will think of viral hemorrhagic fevers, enteric fever, leptospirosis, malaria. These are all infections. There could be also be lymphoreticular malignancies like leukemia and lymphomas. Rheumatological conditions like SLE and SOJ can also present with fever, rash, and abdominal distension.
Okay. Go on.
This child has no history of cough and cold, breathlessness, ear discharge, no history of high colored urine, jaundice, or blood vomiting, no history of diarrhea or vomiting, no history of headache, seizures, visual disturbances, hearing impairment, audible sensorium, no history of oliguria, facial puffiness, leg swelling. When probed, mother tells a history of child, the vague bone pain while being handled, no history of night sweats or oral ulcers.
Divya, can you tell me the cause of fever with bone pain?
Fever with the bone pain can be due to acute osteomyelitis, viral infections like dengue fever, chikungunya, parvovirus. Parvovirus can also cause the bone pain, sir. It can also be seen in hematological malignancies, lymphocytic malignancies like
Why you
leukemia
get bone pain in leukemia?
due to bone marrow infiltration, sir.
Okay. Then why there's a pain?
Marrow is getting involved.
Okay. Involvement of what structure in the bone causes pain?
Sorry, sir. I couldn't understand.
So it is the periosteum involvement, right? This periosteum reaction is going to cause a pain.
Yes, sir.
Now, how are you going to manage this pain? The child has given paracetamol. How are you going to manage the pain in this child? Bone pain.
Steroids can be given, sir.
No. How is
Dr.
the basic?
Rajkumar, can we allow her to present and then ask questions?
Okay, ma'am. Okay, done.
Yeah. Yeah, go ahead and present.
Okay.
For the current illness, she was initially treated as an outpatient with paracetamol and oral antibiotics. In view of persistent fever, she was admitted to an outside hospital on day 6 of illness, investigated and referred to a center for further management as she had pancytopenia. Antenatally, mother was married at 23 years of age, P2L2.
If it is relevant, you tell Dr. Divyaja, unless there is something relevant,
yes,
please do not waste your time.
Antenatal history is uneventful, ma'am. Natal history full term LSES in your previous LSES, birth weight is 2.5 kg, cried immediately after birth. Breastfed initiated soon after delivery, no history of NICU admission, history of fast urine and meconium within 24 hours of life. Diet history. For the expected 1100 kilocalories, child takes 720 kilocalories according to 24-hour recall method before the onset of illness. Calorie gap of 380 kilocalories. For the expected 24 grams of protein, child takes 15.5 grams of protein with a protein gap of 8.5 grams. Attained age-appropriate developmental milestone. Immunized as per national immunization schedule. No special vaccines were given. Family history, no significant family history. Non-consanguineous marriage, elder sibling, a 9-year-old boy, healthy. Summary, 2-year-old female child, second born of non-consanguineous marriage, presented with fever for 1 week and abdominal distension, immunized up to age. Red flags in history, skin bleed and bone pains. Possible differences include tropical fever, enteric scrub typhus, XLH, ITP, or lymphoreticular malignancy. Probable system involved is gastro and abdomen, and so I'd like to examine abdomen first.
Yeah, please stop there.
Yes, sir.
I think you should give more information about the fever. Did you talk about little more about the fever? How was the fever? I mean, whether it was intermittent, high grade, continuous fever. I think because the fever is
Intermittent
the main, fever is the main complaint in this child. So a little more details about the fever. How was the child during the interfebrile period? Was the child well during the interfebrile period? All that is very, very important because you're trying to get more information if you get that particular information, whether the child, what does it mean if the child is well during interfebrile period?
It's more likely of a viral infection, ma'am. Child is not toxic.
Usually inflammatory disorders, they are well during interfebrile period. Okay, suppose it's an SOJIA or, they are well during the interfebrile period, but your viral and enteric and all, they'll be throughout, the fever will be continuous, and even during the interfebrile period, they will be little dull, preferring to lie down. So that is very important. Little more information about the fever. If you had presented, it would have been nice. And will the mother say that it is bone pain? No one will say it's bone pain. Will anyone say it's bone pain? Usually they say it's a severe limb pain. So how do you differentiate normal growing pain versus bone pain? What is the differentiating feature?
Child will sleep normally in the night. Growing pains will go off. Growing pains will go off in sleep, ma'am. But the bone pain will be more persistent.
Usually nocturnal awakening will be there. So you should have mentioned that part. Instead of saying bone pain, you should say the pain was so severe that the child had a disturbed sleep, or the child woke during sleep and complained. Because if you say, normally no one says it's bone pain. It's usually the doctor who identifies that it is bone pain. Clear? Unless the mother touches the child and the child has pain. Yeah. So did she mention that?
She mentions.
She mentioned that, is it? Okay. On touching the child's legs, is it painful?
The child complains. Yes, ma'am. When on touching, when giving massage, the child complains of pain during nights. This was the complaint by the mother.
Fine. Then even then they'll complain of limb pain only. No one will say it's bone pain. I'm still not seen a mother saying that it is bone pain. I think Dr. Rajkumar as well as Dr. SBS sir will agree. No one will say it's bone pain. Okay, these are all medical terms. Whenever you you're presenting history, always use the mother's terminology. Whatever terms she uses, you have to use. Okay.
Yes, ma'am.
Okay.
What are the causes of fever with night sweats? You told fever with night sweats. What do you mean by the night sweats?
Fever with night sweats, morely in leukemia, lymphoma, sir, and also in tuberculosis, a low-grade fever, which is more in the evening. When the temperature comes down, child may experience night sweats.
You told oral ulcers. Can you give me some common cause of fever with oral ulcers?
Herpangina, measles.
Do you get hemato?
Yeah.
Hepatosplenomegaly, you get oral ulcers.
Yes, sir.
Okay, why you get that in leukemia?
Uh,
Oral ulcers, normally you get an inflammatory bowel disease.
due
Or
to gingivitis
if it's an adolescent
or
girl,
gum
you can think of
inflammation.
yeah, it's gingivitis. Gum inflammation can cause,
Gingivitis.
or bleeds itself can be painful. That's what, no, the oral
Neutropenia can
bleeds itself
cause.
can be painful. That's what Dr. Rajkumar, yeah, that's what Dr. Rajkumar is trying to ask you. What is the cause of, painful lesions in the oral cavity? In malignancy, you bleed, and as you went fever for a long duration. Oral ulcers, usually we think of IBD, or you think of
Candidiasis, oral candidiasis can cause.
as you mentioned, yeah, the SLE if it is an older child. Yes. Go ahead. Go ahead with your examination unless Dr. Rajkumar has some more questions.
You told next slide, please. Next slide. Okay, go on. Go on with the examination.
Sir, SB sir, you have anything to add, sir?
Yeah. Thank you, Prasanna. Nice presentation, good presentation. But I have a few more doubts in the history. Can you go to the summary
Yes, sir.
slide? Can you go to your summary slide in the history? Yeah.
Yes, sir.
Okay. Now, you have said that it is a 2-year-old female child. The whole thing has a picture of a fever for a week. And the second symptom, other than fever, Dr. Janani very rightly asked about the pattern of fever, which I would like to know. But of course, sometimes the parents might not note the pattern of fever. So I will excuse you, don't worry. If they had recorded, I would have asked them to show me the record or the recording of the fever. The pattern might occasionally give a clue. One. Second symptom you mentioned is abdominal distension. And you didn't elaborate.
Yes,
Where
sir.
is the abdominal distension? And can you tell me, doctor, why I am asking that question? Where is the abdominal distension? How is it going to help you or me in diagnosis? Did you elaborate where the abdominal distension was?
You said upper abdomen.
Yes, sir. Upper abdominal distension.
Upper abdomen, right or left? Right or left? Symmetrical, asymmetrical, lateral, frontal, where?
Yeah, whether it's a uniform distension or
upper abdomen has a whole lot of regions, Upper abdomen has, right hypochondrium, epigastrium, left hypochondrium. Which portion? Which portion? Where is the distension? And how is that important to you and me? Very simple,
upper abdomen has the whole, sir. Yes, sir.
No. You have a child who has got fever and skin bleed. Definitely, you are going to elicit history of organomegaly in the child, isn't it?
Yes, sir.
And
Yes,
whether
sir.
it is organomegaly or whether it is ascites, you could have easily distinguished from the mother's words whether it is right-sided enlargement, left-sided enlargement, and what happened to the umbilicus. Intelligent mother will even tell you if there is a gross hepatomegaly or a splenomegaly, saying that the abdomen is distended and that umbilicus is even coming down. Without even touching the patient, you can come to a conclusion whether it is hepatomegaly, splenomegaly, or splenohepatomegaly, or hepatosplenomegaly, or ascites. That's one. Second,
Yes, sir.
2-year-old child. 2-year-old child.
Yes, sir.
There are few symptoms which the mother can never identify correctly. Can you tell me which two symptoms related to pain which the mother will never be able to identify very well in a 2-year-old child? Or a 1-year-old child, 2-year-old child? One, your limb pain. Second is your abdominal pain. See, many a time, in Dr. Janani would agree with me, many a time parents will say, doctor, child is crying due to abdominal pain, 1 year, 2 years old. You can't say it. You can never make out whether it's the child won't complain.
Difficult to localize in a small child.
Yeah. That's very, very unusual. That's very, and your limb pain, where were the limbs where there was pain? Was it lower limb or upper limb, symmetrical, asymmetrical? And tell me why I am asking this. Again, I'll make it simple for you. If it is a pain in only one limb, it is likely to be a local cause. Yeah, it can be anything, anywhere, starting from a fracture to a hematoma to osteomyelitis or septic arthritis. Whereas, if it is all the 4 limbs, it is a systemic problem. So you should have, in a child who has got a bleeding into the skin, it could well be a bleeding which can cause pain, a hematoma or a hemarthrosis. Your diagnosis will vary. So that you should have elaborated. So I was not very sure where the pain was, how the pain was. And I don't think growing pain is a diagnosis at 2 years of age. It doesn't occur at 2 years of age. Right? Very, very unusual. As Dr. Janani clearly put it, I think the so-called bone pain in a 2-year-old child is something very different. You can only identify the child is crying probably due to pain. That's all you can say in the history. Okay. Bone pain, I'm not sure how you identified. And the next is, what happened to all the symptoms? Did the fever increase, decrease, or come down? Did the pain increase? You said admitted outside. Did the pain decrease, fever decrease, progress? Any child's symptom, you should always talk about the progress of the individual symptoms. And you should say whether they are worsening, or they are improving. Can you tell me all the symptoms are worsening, improving, or remaining the same?
Persistent fever, sir. It's
persistent. What about pain and bleeding? Is it same?
Skin bleeds remains the same, sir, but limb pains are persisting.
Okay. Now, my next comment on your summary, you have put tropical infection, enteric and scrub typhus. How many cases of enteric fever you have come across with 7 days fever, with bleeding, with abdominal distension from day 2 or 3? How often do you see that in enteric fever? And how often you get enteric fever in a 2-year-old child? I'm afraid both are rare. In fact, I wouldn't think of enteric fever at all in a child who has bleeding within 7 days of fever and history of abdominal distension. I would say enteric fever is straight away ruled out in this child. It doesn't present with bleed.
I'm surprised that she's not put dengue as her differential.
Okay, I'm coming to that.
Yeah, dengue should be one of the differential.
Scrub typhus, the child does not come with bleeding like this from day 2, 3. It all happens in the second week or after 4 or 5 days, child will become sick. The last thing, you talked about bone pain. How was the ambulation of the child? Was the child walking?
Yes, sir.
Did you ask about the gait of the child?
Yes, sir. Child is walking, sir.
Walking. The antalgic gait, normal gait?
Normal gait, sir.
Normal gait. Yeah, that would have given me, that would straight away rule out osteomyelitis and septic arthritis. Second, again, HLH.
Yes,
HLH, how often do you get like this with bleeding so early? I'm afraid no. It occurs in the second week. It doesn't occur so fast. Third, ITP. Again, I'll strike you down. Sorry for being a very, rough and tough. It's not that way. ITP, Dr. Janani would have seen more cases than me. ITP never presents with fever. No, it doesn't come like fever.
And abdominal distension will never be there in ITP.
Yes. All that is against ITP. So ITP is not. The only thing that will come to me, again, this becomes nearly like a PUO 7 to 8 days. Infection, inflammation, malignancy, miscellaneous. I think in this child, infection very unlikely. That's what I would say. It doesn't present with abdominal distension, bleeding, and pain. So it is, and 2-year-old child, I'm not going to think of an inflammatory disorder. And you said JAA, you can't make a diagnosis in 1 week. So I don't think I will think of JAA at all. So straight away, I would say the first diagnosis, your differentials should become different. First should be lymphoreticular malignancy. Second should be
Viral hemorrhagic fever.
infection. Again, dengue. Don't use the term viral hemorrhagic fever, man. That's just not. We don't use the term anymore. Dengue hemorrhagic fever, viral hemorrhagic.
Used in all government hospitals still.
Yeah. See, two things. Dengue does not cause fever for more than a week, ma. Again, that rules out dengue almost. I don't think you would expect a child with dengue to have abdominal distension right on day 2 with pain and all. With limb pains are a feature of dengue in adults and adolescents, not in a young child like this. So I don't think I'll consider dengue. Unusual infection, which could also include like, for example, scrub typhus, rickettsial, I would agree.
Brucellosis.
Leptospirosis is not ruled out. Because of the limb pain, brucellosis has to be thought of, right? That's what I would think of. And last but not the least, you said probable system is involved gastrointestinal tract. I don't know, you never said any symptom related to tract. There is no vomiting, there is no diarrhea, there is no hematemesis, there is no melena. So I don't think this is a gastrointestinal tract problem. This is probably a
lymphoreticulaar system.
Problem related to reticuloendothelial system or lymphoid system affecting the liver and spleen. These are all my thoughts. Sorry, Dr. Janani, I took quite some time.
No problems.
These fundamentals should be stressed.
Thank you.
Please go ahead.
Fundamentals,
Divecha, you told
more details about the history is very important because you'll be stopped at the history itself. You won't even proceed with your physical examination or discussion. You'll have time only for history. So history has to be very detailed, very elaborate, like what Sir told, and your differential diagnosis has to be it should be practically fitting into whatever you're finding.
And finally, you should have also mentioned
whether textbook description or something like that.
Yeah, you should also have mentioned whether the bleeds were palpable. So-called bleeds. Sometimes,
HSP is another thing.
HSP might be mistaken for a vasculitic rash, might be mistaken for a bleed, ecchymosis. So that also you could have, but you very clearly said the color had changed to blue, which indicate that this is likely to be a cutaneous bleed. This is likely to be a platelet problem, either qualitative or quantitative. Okay? Right. Please go ahead.
Yes.
Go ahead.
Divecha, you are telling that the child had pancytopenia evaluated outside. Where is that?
Yes, sir.
Now, the pancytopenia will be.
Yeah, you're right. She had mentioned.
Yes, sir. She had pancytopenia. Now, can you give me where does your different diagnosis narrow down to? A child has fever with pancytopenia. 7 days fever with pancytopenia.
Fever with pancytopenia could be marrow replacement due to leukemia, myelodysplasia, or myelofibrosis.
Okay.
Due to increased destruction or sequestration as seen in malaria.
Okay. What malaria probably?
Malaria.
What species?
Malaria, both can cause vivax as well as falciparum can cause.
Falciparum malaria more probably causes severe malaria. So severe malaria can cause sequestration and hematuria kind of thing.
So, what is your cutoff for pancytopenia as such? For hemoglobin?
Hemoglobin less than 10.
Okay.
Total count less than 4.5, 4,500.
Okay.
Platelet less than 1,50,000.
Go back
Go
and
on,
check.
go on.
I don't know hemoglobin, whether it's less than 10, you include it as for pancytopenia. I think probably check the definition. Go ahead. Go ahead.
Fever with pancytopenia can also be
We have
seen.
another half an hour left. You go
Viral-
ahead.
Go to the examination.
Go on to examination. We have another half an hour only. Yeah.
General examination, child appears conscious, alert, cooperative for examination, comfortable, sitting in mother's lap, non-dyspneic, oral cavity normal, no petechial leaks or no gum hypertrophy, no tonsillar enlargement, no patch over the tonsil, neck bilated, discrete, non-mated, non-tender, 4 lymph nodes measuring 1.5 centimeter palpable in anterior cervical region, no focus in the skull, oral cavity, PCP scar present. Ecchymotic patch measuring
Diveja,
2
you
×
told
1
this
centimeter.
previous slide, please.
Yes, sir.
Now, what do you mean to say that there is no patch over the tonsil? What do you want to convey to us?
Tonsil is not the focus for the bilateral cervical node enlargement.
Okay, the tonsil
No,
enlargement
but
is
is
not
it
due to
relevant?
infection.
No, it's not relevant to this child, no? Is it relevant to this child?
No, ma'am.
Yeah.
Doctor, it is wrong to use such words like patch. You should only say no exudates are seen on the tonsillar surface. I think patch is neither
Patch is,
radiologically
yeah.
correct nor throat-wise it is correct. Right?
Yes,
It's a layman's
yes, sir,
term.
yes, sir.
Yeah,
I'll
layman's
correct,
term.
sir. Yes,
The
yes, sir,
layman's
correct.
terms. Avoid using such terms. Many examiners would object to you using such terms. Okay, please correct.
Yes,
It's
yes,
no
yes, sir.
exudate, and the tonsils were looking healthy, right? And
Yes, yes, sir.
so, right, in a 2-year-old child, you don't expect anything in the tonsils, right? Fine.
Okay, sir. Yes, sir.
Go ahead.
Ecchymotic patch measuring 2 × 1 centimeter in the back near the sacral region, 1 × 1 centimeter in the left thigh anterolateral aspect. Skin, no ulcers, no hyperpigmentation.
Now,
Abdominal
Diveja,
distension.
these skin pigment, these bleeding patches, why they are more common in back and the legs?
Pressure zones, sir.
Okay. You're speaking about hyperpigmentation, right? What do you mean to want us to convey to us?
Sir, hyperpigmentation along with skin bleeds may be a nutritional cause as seen in vitamin B12 or folate deficiency.
Okay.
It can be coexisting, so I want to rule out nutritional causes here.
Okay, go on.
Abdominal distension seen more in upper abdomen. Limbs, multiple axillary and inguinal lymph nodes measuring 1.5 centimeter to 2 centimeter palpable. No bony deformities, spine normal, genitalia normal, plus no intracyanosis, clubbing and bleed edema. Anthropometry, weight for the expected 12 kg, child is 10 kg, between 10 to 25 percentile. Height is 79.5 centimeter for the expected 83 at the 50th centile. Mid circumference is 14.5 and head circumference is 48, appropriate for age. Vitals, heart rate is 118 per minute, pulses normal volume, regular rhythm, no specific character, felt in all peripheral vessels, no radioradial or radiofemoral delay, no vessel wall thickening seen. Respiratory 30 per minute, abdominal thoracic type, blood pressure 90-70 millimeter of mercury in right arm in sitting position. System examination, abdomen inspection, abdomen distended, flanks free, umbilicus pushed down, skin over the abdomen normal, no dilated vein, no scars or sinuses, no visible pulsation, peristalsis, hernial orifice is free, genitalia normal, no renal lung tenderness, no renal lung fullness. On palpation, on superficial palpation, no warmth, no tenderness. Abdominal girth is 45 centimeter. Liver palpable 5 cm below the right costal margin in mid-clavicular line, firm in consistency, round margin, smooth surface, non-tender. Liver span is 8 cm. Spleen palpable 3 cm below left costal margin, firm in consistency, non-tender. Splenic arch could not be felt, moves with respiration, not able to insinuate fingers into the costal margin. On percussion, there's no free fluid. Bubble sounds are heard, no audible bruit. Cardiovascular examination, S1 head, soft systolic murmur of grade 2 or 6 heard in pulmonary area, no radiation. S2 head, RS bilateral air entry equal, no added sound. CNS, no focal neurological deficit. Positive findings on examination, pallor, generalized lymphadenopathy, ecchymotic patch, hepatosplenomegaly.
You want to change your differential diagnosis or add something after your physical examination?
Yes, ma'am.
What is something that different that you found in general examination, in physical examination?
I found generalized lymphadenopathy, ma'am.
What is the finding that
Pallor,
is lymphadenopathy? So would you like to, would you like to add or delete or change the order of your differential diagnosis?
My differential diagnosis, the first one considered as lymphoreticular malignancies. Second would be tropical infections, unusually tropical infections like scrub type or leptospirosis. And the third would be rheumatological conditions.
Which rheumatological infection will have all these findings? It's unlikely. I would probably add an EBV infection as one of the differential diagnoses after your general physical examination. With so many lymph nodes, pallor, everything will fit into EBV. Yeah. EBV, again, it's a forerunner of a malignancy. So EBV also should be considered. Then, of course, your lymphoreticular malignancy. And rarely some tropical infections like what Sir mentioned, brucellosis. Scrub typhus again looks unlikely. Yeah, brucellosis, melioidosis are all rare tropical infections which you should consider. The child was not febrile at all, because you never mentioned about fever in this child. Was the child febrile or not? When you examine, was the child febrile or not? You never mentioned that.
Yes, ma'am, febrile. Sorry, ma'am, the child was febrile.
Sick looking or well looking? Go back to your first slide in the general physical examination.
Comfortable in mother's lap, ma'am.
That's fine. Was it sick looking or irritable or comfortable, playful? All that is important, no? More than conscious, you should say whether the child is playful. I mean, if it's very not irritable, whether the child is febrile, sick looking, you can automatically look at the child and say, okay, this child is looking well, this child is looking sick. That particular description has to come instead of saying conscious alert. What do you mean by conscious alert? Doesn't make any sense, no? Instead, you say that the child is febrile, sick looking, cooperative for examination, sitting on the mother's lap. That is fine. You should say febrile and sick looking should be added. Okay.
Okay. Yes, sir.
No conscious alert and all is not correct. Go to the next. No focus on the scalp. What did you look for in the scalp?
Any abscess.
Abscess.
Any first point. Any first point.
What else? What else will you look for in the scalp in a child with fever, pallor, hepatosplenomegaly? What else would you look on the scalp? You should look for seborrhea or some lytic lesions. You can just palpate and you can see some depressions. Yes, depressions on the. You mentioned scalp, so I'm asking you. Yes, because you mentioned about the scalp, you should know what you should look for in the scalp. Seborrhea again in LCH and a depressed any depression that is felt in the scalp, that is also important. Okay.
Yes, ma'am.
Okay, go to the next slide. We'll just go through the examination whether you missed it. Next slide, please.
Yes, ma'am.
Ecchymotic patch, skin no ulcers, multiple axillary. Were these nodes painful or painless?
Non-tender, ma'am.
Non-tender. Did you look at the epitrochlear region for a node?
Yes, ma'am.
You've not mentioned that, no? Has generalized lymphadenopathy, so epitrochlear region also should be mentioned. And epitrochlear is more found in child with EBV. Okay.
Yes, ma'am.
Okay.
How was the consistency of the nodes?
Firm to texture, not maintained, non-tender,
Okay.
non-rubbery.
Now, what are the common antenatal risk factors for a child with a lymphocytic malignancy?
Sir, sorry, sir, I couldn't hear.
Antenatal risk factors.
Antenatal risk factor, maternal exposure to radiation, certain drugs.
Okay.
According to two-hit hypothesis, first hit in intro and second hit post conception. Sir. Post conception, somatic mutations can cause lymphoreticular malignancy. Sir. Antenatally, maternal smoking, infections, maternal age, obesity, maternal exposure to radiation, maternal
What was the age of the mother at conception?
29, sir.
Okay. Anything to do with any maternal age at conception
No,
to do
sir.
with lymphocytic malignancy?
No, sir. Not here. More than 35 is considered a risk factor.
No. What about a mother who's an elderly primary? Is there any risk factor having lymphocytic malignancy?
Sir, increased maternal age is linked to increased birth of syndromic child like Down syndrome and Conian.
Okay.
They have a more increased susceptibility, increased risk of lymphoreticular malignancy. That way, maternal age and ALL are linked.
So you told the child was immunized up to age. Why is the immunization history important in a child with lymphocytic malignancy?
Sir, an unimmunized child, infections with parvovirus and EBV, which himself cause for lymphoreticular malignancy. If the child is diagnosed with malignancy and started on chemotherapy, we should be careful in giving immunization.
Okay, go on.
I think she finished the presentation.
Okay.
So what is your final impression after the physical examination and systemic examination? Yeah, okay. You want to go ahead with the investigations? Okay. So what is the topmost thing that you think now is lymphoreticular malignancy? Yes?
Yes, ma'am.
You'll have to change the order. Again, you put ITP. ITP should never be there in your differential diagnosis. Okay?
Yes, ma'am.
Okay. So what investigations, before going to the investigations, what investigations would you do in this check? Very important investigations that will give you some clues to the diagnosis. Tell me only some. Okay, CBC with a peripheral smear. Okay.
Peripheral smear.
What do you look for in the CBC? Peripheral smear, what do you look for?
For the counts and blast and the peripheral smear.
What will be the peripheral smear in a child with EBV?
Toxic granules will be seen in EBV.
EBV toxic granules will not be seen. You'll have multiple atypical lymphocytes or reactive lymphocytes. Okay. Sometimes they get confused with the atypical reactive lymphocytes versus blasts. How do you differentiate lymphocytes and blasts in the peripheral smear? Atypical lymphocytes or reactive lymphocytes. Okay, that is one. See, atypical reactive lymphocytes, the lymphocytes will be of different sizes, and you'll have a lot of pseudopodia and all that, and then there'll be RBCs will go and get linked to the lymphocytes.
With the lymphocytes.
Yeah. Whereas in lymphoblasts, it will be similar identical cells. Multiple sheets of similar identical cells is blast. Different looking cells, varied sizes with pseudopodia is usually reactive lymphocytes with RBC rosetting. That's one thing that you should know how to differentiate between blasts and reactive lymphocytes. It's very, very important. Okay.
Yes, ma'am.
Yeah. What else will you look at? Peripheral smear, CBC, fine. You're going to look at all the cell lineages. You're going to look at, you said pancytopenia outside. That's why child was referred. No, you're going to look at differential. Differential, what will you look at? Again, lymphocytes, no?
Lymphocytes.
Yeah, lymphocytic predominance is predominance. Okay, fine. What other investigations would you do in this child? What other relevant investigations will you do in this child, apart from CBC and peripheral smear?
LFT.
LFT, okay. So what do you look for in LFT?
OTPT might have been.
Transaminitis is one thing. You should also look for albumin, whether the albumin is affected and whether there is coagulopathy.
Can also.
Yeah, because yes, hypoalbuminemia, and you also mentioned ecchymotic patches and all that. So you should also do the PTA has to be done. Yes.
Yes, ma'am.
Fine. Okay. Then what else will you do?
LDH, serum
LDH, yeah, the LDH is important. Okay. What else? You said nodes, you said lymphadenopathy, you said hepatosplenomegaly. So what are you worried about in this child? What biochemical complication can happen in this child? So what other investigations are more important in this child? Very important to look at the renal function test, your calcium, your uric acid is very important, no?
Yes. TLS workup has also been done. Calcium, phosphorus, uric acid level.
Yes. Very, very important, no? So what are the varied presentations of? Yeah. So what are the varied presentations, other presentations of lymphoreticular malignancy that you know of? This child had fever, pallor, hepatosplenomegaly. What other ways it can present? What other ways it can present?
Non-specific symptoms like malaise,
what are the emergencies? What are the emergencies with which they can present?
Hyperkalemia, AK, uremia.
Superior mediastinal syndrome, no? Superior mediastinal syndrome.
Upper RBF, superior mediastinal syndrome. Testicular enlargement, testicular torsion.
Yeah, can present with any of those. They can present with just pallor, just thrombocytopenia and bleeds.
Can CNS is involved. They can present with the irritability. CNS can also be there.
Yeah, okay. We are talking about leukemia. Okay, CNS leukemia is very, very rare. To start with, it's rare. So let's stick to more of a systemic involvement. So it can present as isolated pallor, can present with fever, pallor, hepatosplenomegaly. This child is telling, okay, I'm having lymphoreticular malignancy, but not all of them present in this typical manner. No?
Yes, ma'am.
So sometimes they present with non-specific symptoms with fever, limb pains. They can go to orthopedic surgeon. They can go to just for a physiotherapy, or they can go to a neurologist thinking that it's some neuralgic pain. So different ways different specialists it can go. We've seen some of these children with skin bleeds, rashes, like thing, they go to a dermatologist, then they come, it leads to the hematologist. So different ways of presentation, various emergencies with which they present, you should know. Okay. And that is all important for your practicals as well as your theory. It's very, very important. Okay, then what else? How do you confirm your diagnosis? Will you not do an X-ray chest or an ultrasound abdomen on this child?
Yes, ma'am. Ultrasound.
X-ray chest, what would you look for? X-ray chest, what would you look for?
Mediastinal march.
Look for hilar enlargement, mediastinal enlargement.
Yeah. Mediastinal push.
And whether there's any pericardial infusion, pleural effusion, all that you should look for.
Yes.
Okay, and
Yes,
also sometimes lytic lesions in the ribs, if you're dealing with a HLH or something. Lytic lesions in the ribs also you should look for. Okay. Then ultrasound, what are you looking at?
Liver and spleen enlargement.
What will happen to the kidneys in the ultrasound in these children? They'll have a bilateral nephromegaly. Any infiltrative disorder, you'll have a bilateral nephromegaly. Okay. So you look for that. And sometimes you can also pick up some nodes in the omental region and the mesenteric huge nodes in the mesentery. Yes, para-aortic, multiple nodes you can pick up. Can be even a lymphoma or can be even an NHL or a HL. Yeah, so you're just telling leukemia because, but also these things also fall into the same group, lymphoma, leukemia, anything, okay? Okay, did you mention the blood pressure of this child? What was the blood pressure? Was it normal?
90-70.
So tell me some malignancies where the blood pressure will be very high. Which are the malignancies where the blood pressure will be high? Can you hear me?
Yes, ma'am.
Yeah, with hypertension.
Wilms
Wilms. Okay. What other malignancies? Where you'll have hypertension. Neuroblastoma and pheochromocytoma. Okay.
Yes, ma'am.
These are the two malignancies where blood pressure measurement is very, very important. Okay. Okay. Then when you do a bone marrow on this child?
Yes, ma'am. Bone marrow study has been done.
Yeah. Now, what was the percentage of blasts in the smear?
Actually, 30% was the blast, ma'am.
Yeah. If the blast percentage is more than 50%,
more than 20,
you don't need, you don't need to do a bone marrow at all. You can straight away do a, what is the other test that you do with the bone marrow and with your blasts in the peripheral smear? What are the other investigations you'll do?
Immunophenotyping and cytogenetics.
Flow cytometry is very important. Very important because you need to know what is the type of malignancy. Okay, what is the common type of, what is the commonly encountered type of leukemia?
ALL is the most common.
ALL, within ALL, which is common?
B-ALL, B-cell ALL.
T-cell is not common. T-cell is high risk. Not very common. Pre-B leukemia. Okay. Pre-B cell leukemia is more common. Yeah. That's more common. Your T-cell is high risk and it's not that common. Okay. Okay.
Divya, is your thrombocytopenia a contraindication for doing a bone marrow?
Yes, sir. Before doing a bone marrow study, we need to support. We need to increase the platelet count more than 50,000.
Not really. No, not at all. Divya, you need not wait for the platelets to increase and then get a diagnosis. You do it and apply a firm pressure, and you can always reserve some platelets if needed. You can give. You will not wait for the platelets to increase and then do a bone marrow. Okay. In all your children with ITP and all, we do the bone marrow. Even if it's 10,000, do you wait for it to increase? You should just apply a firm pressure on the site of bone marrow, okay? So you don't have to wait. There is no contraindication. That's why sir was asking. There is no contraindication to do a bone marrow in a child with thrombocytopenia. You have to take precautions, and I give firm pressure and prevent child having a huge hematoma. That's all. You'll never wait and increase the platelet count and then get a diagnosis. Clear. In ITP, what will happen? If you keep giving platelets, everything will get destroyed. So where is the question of platelets going up? Clear.
Yes,
Not a contraindication. I would agree if you say LP, lumbar puncture is a contraindication, but not a bone marrow. Clear. Lumbar puncture is a contraindication because you may end up with a hemorrhagic fluid and you will not get a proper diagnosis. But from bone marrow is not at all a contraindication. Clear.
Yes, ma'am.
Not a contraindication. Okay. You go ahead and do, even if the platelet is less than 10,000, you can go ahead and do a bone marrow. Clear.
Okay, ma'am.
So what was this child having? What is the final diagnosis in this child?
Child has a B cell ALL.
B cell ALL. Okay.
We have referred the child to ICH for further management.
Okay. So what are the drugs?
How is your age and the gender of the child is going to affect your prognosis in ALL?
What are the prognostic factors? That's what he's trying to ask. How do you classify standard risk and high risk? You classify
the high risk. High risk less than 1 year and more than 10 years. For standard risk 1 to 10 years, which has a better prognosis. A girl child has a better prognosis than boys.
Those are all now not at all applicable. Okay. Those are all older classifications of standard risk and high risk. Now with the advent of flow cytometry and your immunophenotyping, those things don't have a say at all in your risk factors. But previously, we never had flow cytometry, and immunophenotyping was not available. We just used to do a PAS stain and find out whether it's L1, L2 or L3. And then we used to use this risk factor classification. But it's good to know, but not anymore relevant because the current advancements in technology, okay, and your diagnostic modalities, not anymore relevant, okay.
Okay.
Sir, if you want to ask anything, sir, SBS, sir.
Yeah, very, very nice presentation. Few comments. One in the physical examination, was there more hepatomegaly or more splenomegaly? Which was more?
Hepatomegaly, sir.
Pardon?
Hepatomegaly, sir.
Hepatomegaly. Okay, right. One. Second, one of the presenting symptoms you had was bone pain, and you never described the examination of the limbs. Whether you found any mass, any bony lesion, bone tenderness. Particularly, bone tenderness can be elicited even in a 2-year-old child over the sternum. 2. Third question I wanted to ask you, you said that there is generalized lymphadenopathy. Generalized lymphadenopathy. On what basis you identified generalized lymphadenopathy? What is the definition of generalized lymphadenopathy? What is the important difference in physical examination clue when it comes to differentiating the generalized lymphadenopathy and the regional lymphadenopathy? Any student can put in the chat box also if they know the answer.
Generalized lymphadenopathy means enlargement of more than 2 non-contiguous lymph nodes.
Excellent. But then there is one subtle difference between generalized lymphadenopathy and regional lymphadenopathy. I'll just give you an example. You have a child who has got lymph nodes in the axilla 1 centimeter, lymph nodes in the inguinal region 1 centimeter, inguinal axilla 1 centimeter, cervical 1 centimeter, epitrochlear 0.5 centimeter. Is that regional lymphadenopathy, or is that significant lymphadenopathy, or not significant generalized lymphadenopathy?
The cervical lymph node more than 1 centimeter.
Okay. Now, to save time, I'll help you. Don't worry. The important point that I wanted to stress is that when it comes to definition of generalized lymphadenopathy, size does not matter. Only for regional lymphadenopathy, size matters. For example, you have a child who's got 0.5 centimeter lymph nodes everywhere. That is generalized lymphadenopathy. You can't say it is not significant. Okay. So that's a very important point I wanted to drive home. And the third thing I wanted to tell you, please go to the slide on the investigations. Go to the previous slide of differential diagnosis. No, previous slide. Yeah, just keep it like that. In this child, of course, Dr. Janani clearly struck off the ITP. Okay. You are left with these two. If I were you, I would have added a third possibility in this child. What is that possibility? Because you said the neutrophils are low. You said child is having fever for 1 week. There any other addition to this you could have put in the differential diagnosis?
Immune deficiencies.
No, okay. I'll help you. Don't worry. Whenever any child with suspected leukemia comes to you with fever, you can make a dual diagnosis. What is the dual diagnosis? Febrile neutropenia with severe sepsis.
Yes, sir.
In fact, that is what I would have put in the second. First thing I would have put lymphoreticular, because you already said in the presentation that this child had pancytopenia. So febrile neutropenia, in addition to lymphoreticular malignancy, if it is there, I would have added lymphoreticular malignancy with febrile neutropenia with probable sepsis. Combo. Okay.
That's another way,
Yes,
the
sir.
emergency that a child with leukemia can present.
Absolutely.
Febrile neutropenia.
Absolutely. That is the. And in addition to this, with this child having been ill for 7 days, child being only 2 years of age, with this sort of presentation, because you have put broadly lymphoreticular malignancy, I would have put a broad diagnosis of histiocytosis, including HLH as a last diagnosis. You might be wondering, I objected to this in the history, now I'm coming back. But I would definitely have considered that in the differential diagnosis of this child. Okay.
HLH we should consider.
Yeah, HLH and sometimes HLH or histiocytosis. Your LCH can present 2-year-old can exactly present like this. And then please go to the next slide. Please go to the next
Investigation slide.
Yeah, in the investigations, of course, everything is fine. In the X-ray chest, in addition to what Dr. Janani said, you look at the thymus, you look at lymph nodes, you also look outside the ribs and chest and heart. You look for leukemic lines in the upper ends of humerus, because the X-ray is very small. In fact, sometimes the radiologist can pick up even leukemia radiologically. It's not very reliable, but that's something which you should look for when you read the X-ray like this. And one other investigation I didn't see in your thing, I would have considered doing is HIV. I think any child with fever 7 days hepatosplenomegaly, thrombus with or without thrombocytopenia, PUO, HIV should be included in the investigations, and more so, even if you confirm leukemia, you have to do HIV. Though, of course, nowadays, antenatal HIV screening is done. So it's very, very unlikely, but, any test can need not be always 100% specific and sensitive. Of course, one question I wanted to ask you, exam question. If this is leukemia clinically, this is leukemia clinically, how do you differentiate clinically without investigations a lymphocytic leukemia and a non-lymphocytic leukemia? What are the differences in terms of clinical clues for a clinical diagnosis of lymphocytic versus non-lymphocytic? If these things are there, lymphocytic is likely. These things are there, non-lymphocytic is likely. Can you give some points, please?
Lymph node involvement, sir.
Lymph node involvement favors what?
Lymphocytic.
1, 2, yeah.
Spleen involvement.
Spleen, you can get in any leukemia. It's nothing. Okay, I'll give you clues. Is a male child, testis mass is there. What
More
type
of a
of
T-cell.
leukemia it is?
More likely
T-cell.
leukemia.
T-cell leukemia. Okay. Child has got superior medias syndrome with dyspnea and engorged veins. What type of leukemia?
T-cell. Okay.
Supramediastinum mass.
No, what type of leukemia?
T-cell only.
T-cell leukemia.
T-cell. Child comes with proptosis. What type of leukemia?
CNS involvement. T-cell.
No. Proptosis is non-lymphocytic. Non-lymphocytic. Myeloid is more likely. Child comes with gingival hypertrophy. Again, non-lymphocytic. Child comes with chloroma, greenish. See, you said blue. Suppose you had got a history that there is some swelling over the bone which has turned green. You would have thought of chloroma and a non-lymphocytic leukemia. The child comes with DIVC. Again, non-lymphocytic leukemia. Gingival hypertrophy, non-lymphocytic leukemia. Okay, like this,
yes,
you have to take all the clues that are there clinically to try to identify what leukemia this one is likely to be. So with this background of generalized lymphadenopathy, pancytopenia, hepatosplenomegaly, this looks more like a T-cell leukemia clinically. You can make a clinical diagnosis. Because of course, Dr. Janani very clearly said, sometimes lymphoma stage 4 can exactly present like this, right? Okay. These are my comments at this point of time. Over to Dr. Janani and Rajkumar.
Yeah, for one final thing, this is probably a price question. Suppose this child, the same presentation, you're making a diagnosis after looking at the X-ray. What do you think there? Just the X-ray gives you the diagnosis. Same presentation, fever, pallor, hepatosplenomegaly. Just looking at the X-ray, you make a diagnosis. What condition is that which you may diagnose just looking at the X-ray? Osteopetrosis, no? Osteopetrosis, yeah, the PG has put in the chat box. So always remember, do not forget osteopetrosis as one of your differential diagnoses in any child with pallor hepatosplenomegaly, plus or minus fever. Okay, because that is one thing where bone marrow is contraindicated. So if you have not done an X-ray or the X-ray has been done in the past outside, not a very good exposed film, please order for an X-ray before you decide on your further investigations, because that is one thing which can be diagnosed. And what will be the peripheral smear picture in a child with osteopetrosis? There is a classical peripheral smear picture which happens in osteopetrosis. Are you aware of that? It's leukoerythroblastic picture. Okay. Usually they get referred as acute myeloid leukemia because of pallor, hepatosplenomegaly, and bleeds. But finally, if you do an X-ray and you look at the smear, you make a diagnosis of osteopetrosis. That is one more differentials you should never forget. Okay. I think if Dr. Rajkumar has any questions, he can ask.
Yes,
Otherwise, I think we can wind
Dr.
up.
Janani, just one more comment on learning for the postgraduate.
Yes, sir. Yes, sir.
Yeah. See,
Yes, sir. Yes, sir.
in thrombocytopenia, any child with isolated thrombocytopenia with normal prothrombin time and partial thromboblastin time, there is no need to do, there's no need to worry about low platelet count. This is fundamental hematology. That is, in children with thrombocytopenia, there is enough tissue thromboblastin available in the alternate pathway of coagulation, which does not depend on platelets, which is good enough to take care of any bleeding which is going to arise when you do a bone marrow biopsy or a bone marrow aspiration.
Yes.
That is
There's
a
no
fundamental
contraindication
point.
at all.
So tissue thromboblastin will take care of bleeding when you do a bone marrow. Unlike a child who has got abnormality in prothrombin time due to a liver disease or a partial
Coagulopathy is a
time,
contraindication.
yeah, that is a contraindication, and no thrombocytopenic child should be deprived of bone marrow because of this. Tissue thromboblastin, even in small amounts, will take care of bleeding. Shouldn't worry. You shouldn't worry at all. This is something which you postgraduates must always remember. Never delay bone marrow because of low platelet count. Don't ask for any further tests. Of course, PTT you are going to do as part of workup when you do when there is a child with bleeding.
Now, Divya, the child has been immunized up to age, right?
Yes, sir.
So now you have diagnosed child to have B-cell ALL, going to start on chemotherapy. Now, how are you going to proceed with the immunization of the child, further immunization?
Live vaccines are contraindicated
During chemotherapy, okay. What about
2
IM and
years?
subcutaneous vaccines?
No, 2 years already child would have finished all the primary immunization, no?
Yes,
Yeah.
sir.
You
One and
want-
a half year vaccine has been completed.
Yes, completed. So you're not really worried. So you can probably do the other boosters, second boosters, and other vaccines which have been left after the chemotherapy is completed.
Therapy is
Okay.
completed.
How
Yes,
long
sir.
does the chemotherapy is given for how many years? Any idea?
The
Usually it's
total
for
therapy
around 2.5 years. Around 2.5 years. Yes.
2.5 years.
2.5 years at least. Okay. So after that, you can give the other vaccines. Because the child is lucky, already 2 years, so would have completed all the primary vaccination, including the first booster. If they are compliant parents who will give the vaccines correctly, who have given the vaccines correctly, then you don't have to really worry. They would have finished all the primary vaccines. So you're left with only the second booster. You can always give that a little after the completion of your treatment, which will be correct 4.5 years. If the child was less than 2 years, or the child was at 1 year old at the time of diagnosis, then you have problems. You'll have to withhold vaccines, all the live vaccines, and give catch-up vaccination after the child completes the chemotherapy.
Completes the therapy.
Yeah. Okay. You should also read up and know about some chemotherapy drugs. What are the drugs that are used? What are the side effects? All that you should know. For want of time, we are not discussing all that, but at least you should know what are the drugs: vincristine, adriamycin, L-asparagine. One side effect of each drug you should know. You have, if the examiners get bored asking about clinical examination, and if you're the last candidate, they may just ask you about some drugs to make the presentation and to make the discussion more interesting. So please learn about all the drugs that are used and what are the complications of each drug you should know. One complication at least of each drug. And as Dr. Rajkumar mentioned, immunization is very, very important.
How about immunizing the contacts? Which vaccination you don't want to give to the contacts?
For households, we can give all vaccines, sir. OPV is contraindicated.
OPV
Okay,
is
you don't want to give them a oral live vaccines, right?
Yes, sir. Instead of OPD, IPD can be given to household.
Okay.
Prasanna, I think time is over, we can close.
Dr. Divyaja,
Yes,
Tangal sir wants a photograph of you with all the teachers. You have 3 or 4 DNB examiners here. So
yes.
please show your face. Tangal sir, you can also join us, sir. I saw Tangavel sir from right from first. He's there.
Yeah, I know. He joined even before Divyaja.
Yes, sir. Yes, sir. Yes, madam. So very good presentation, Dr. Divyaja. I think your
And
face.
Divyaja, you're bold enough to face the 3 examiners thronging you with questions in between. I think that was very good, very sportive, and you answered most of the questions. Good luck, and read up
Thank you.
little more detailed presentation is
He's a second
necessary.
year postgraduate, madam. Very bright second year postgraduate.
Very good, very good, very
Tom
good.
Sundaram sir, she is presenting in Marina Pedican award paper.
Very good, very good.
Thank you.
Along
Tower
with
in my area is not good. Sorry, I had to lost connection.
Yeah, even now your voice is breaking.
sir, you can.
Yes, madam. Yes, madam. Yeah. So it was. Yeah. Now it's clear.
Yes, sir.
Clear.
Yeah, now it's clear.
Yeah. So I was able to join only after 8:30. So once, after my tower improved, so it was a great presentation, Divyaja. So good training for you, and the teachers were real. As an examine, how they were all the 3 were great. Teachers and examiners, so you have done your great job, and you will be bold enough to face such examiners in your 3rd year examination. Good luck to you, and as usual,
Thank you, sir.
madam.
Thank you, sir.
1 minute, sir. Sorry, sir. Tangavel sir, please switch on your camera, sir. Tangavel sir.
Yeah.
Hello.
Sorry, here. Yeah.
Somasundaram, you also switch
I will
on.
also. Yeah, I will
Don't
also
talk,
switch
but just switch on. Yeah.
Yes, sir. Everybody wants a photograph with these 3 stalwarts, sir. Somasundaram sir, am I right, sir?
Hey, if you had told
Definitely,
me, I would have
Prasanna.
put some makeup
They are
and all at them then. Divya, you did a great job. Divya, you did a
Thank you,
great
sir.
job. It was an excellent
Have a
presentation.
default.
Okay,
Thank you,
excellent.
sir.
We examiners will always try to shake the candidate and get the best out of you. Yeah, good, well
Yeah.
done.
Thank you.
Yeah, well done. Yeah. Thank you.
Sir, anything, sir? Somasundaram sir, any points you want to add?
Voice is
With
breaking.
The voice is breaking.
Breaking. Yeah. It's okay.
So we have done with the 10 sessions of this virtual Gurukulam. So my heartfelt thanks to SPS sir to be with us for every session. We'll go with 2 more probably this next month, and my tenure will be over by then, and we'll catch up with the next year at the IAP Tamil Nadu sessions. And thank you both the faculties. Both were very interestingly taking their session forward. Thank you, Janani ma'am and Rajkumar, for sparing your time.
Thank you,
And
sir.
important thing will be we'll be having the Marina Pedican. All these faculty people who are there with SPS sir, Thangavelu sir, Janani madam, all are there as faculties. Request all the postgraduates to register. The topics are all mixed: endocrinology, perinatology, vaccines, infectious diseases, all are there. Request all the postgraduates. So as a special offer, we gave 1,500. So since we got more sponsors, we gave a special offer of 1,000 rupees, which is still continuing till the last date. We are extending the 1,000 rupees for the postgraduates. So use this as an opportunity for all the postgraduates. Thank you, and over to Prasanna.
Thank you, sir. Thank you, Dr. Nisha, for co-hosting. Thank you, everyone, madam.
Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thanks for the
night.
opportunity, sir.
Thank you.
Thank you.
Thank you, sir. Thank you,
Thank
sir.
you.